Hi, good evening, everyone. Welcome to the Young Turks group again. And today we'll be having a journal club. And our first expert is Dr. Leena Wadhwa, ma'am. Ma'am is professor and HOD, senior IVF consultant, ESI Medical College, Alwar. And ma'am is a treasurer of Indian Fertility Society 2024-2026. And ma'am has been accredited with the starting of the first IVF center of ESI at Delhi, and ma'am is advisor to various ART programs, Government of India, and ma'am has numerous research papers and publication. I welcome you, ma'am.
Thank you.
And our second expert is Dr. Gunjan Bhatnagar. And she's done her fellowship in reproductive medicine under IFS. She's done her MD Obs and Gynae from MAMC New Delhi. And she's also been trained in gynae endoscopy and ultrasound from Rejoice Hospital, New Delhi. She runs her own IVF center and has a lot of experience. She's executive member of UP chapter IFS and currently faculty at ICAT Academy, New Delhi. So I welcome you, Dr. Gunjan, as an expert for the journal club.
Yeah, thank
Yeah.
you.
And our speaker today will be Dr. Anuj Sharma. She's registrar IVF Center in Guwahati Medical College. 7 years. She's been worked as a 7 years as consultant gynae and infertility at Border Security Force. And she also has a number of research articles published in national and international journals. She has area of interest in reproductive endocrinology. So, Dr. Anuj, you can carry on with the journal club.
Okay. Thanks a lot. Good evening to everyone, all the seniors, consultants, and thanks a lot for giving me this opportunity so that we are discussing an important topic today, which concerns such a common topic that every day when we sit in OPD, I think major chunk of the patients that we encounter are from endometriosis. Before starting, I bow to Ma Kamakhya, who is the goddess of fertility, and take blessings from her. Before all of my presentations, I do that. So today, the topic that we are going to discuss is, this is a meta-analysis, a systematic review, which was published in 2023. So it's very recent meta-analysis. And it has 5 studies which are under analysis. And out of these 5, all of them, the study was conducted somewhere around 2019 to 21, and the studies were published in around this time only, not before than that. So we can say that a recent update of endometriosis, how the outcomes can be changed using this particular molecule called Dynogest. This will be discussing today. It's a meta-analysis which was published in Journal of Ovarian Research in 2023, and the country of origin was China. The researchers which are just first, and Mr. Wenqing and Mr. Yanli, they are from the Department of Gynae, some university in the Xi'an district, China, and the second one was from Department of Hematology. So whenever we are talking about endometriosis, all of us know that this disease occurs in up to 50% of infertile women, and approximately 30% to 50% of the patients with endometriosis, they suffer from infertility. Hence, when the problem arose with all the practitioners about optimizing our ART outcomes of the patients with endometriosis, the only molecule that we had in our hand was GnRH agonist. Different permutation combinations, basically to down-regulate the patients, they were being performed by everybody. Some people were using GnRH depot or long protocols, a 3 to 6 months down regulation. And yes, we did got some improvements in our IVF results also. Prior to surgery, post-surgery, GnRH analogs or GnRH agonist, depots or short-acting, they were used in full-fledged. For many decades, this was being used. But then came a molecule called Dynogest. Although we will discuss about this particular molecule later, the pharmacokinetics or pharmacodynamics also, but Dynogest as such, in plain simple word, it's a pure simple progesterone receptor agonist, and it has selective receptor activity towards the endometrium. So Dynogest is the molecule which actually came somehow as a savior and as an alternative to GnRH analogs. Hence, this study, it intends to comprehensively assess the influence of DNG or Dinogests treatment versus non-Dinogests treatment preceding IVF-ET on the outcomes in these patients with endometriosis. It's a systematic review and a meta-analysis. All the non-Dinogest group that I'm saying, further the subgrouping was done in the non-Dinogest group. The subgrouping, we will discuss it later and we'll see it later, how the subgrouping was done and which were the subgroups which were made. Starting with the inclusion criteria. Inclusion criteria were simple, that any articles on the patients with endometriosis, and these articles should have a case and a control group, so that one group receives Dinogest and the other group is non-Dinogest group. And then the primary or the secondary outcomes should be retrieved oocytes, mature oocytes, blastocysts, clinical pregnancy rate, live birth rate, which was the must, transferable embryos, and fertilization implantation rates. Then randomized control trials were welcome and cohort studies. These were the inclusion criteria. Exclusion criteria were any animal experiments or non-English studies, or those studies which were already reviews or already meta-analysis or any case reports, individual case reports, they were not taken. Hence, finally, when the whole of the literature was searched, so out of the major 2017 records which were identified and which were searched, especially in all the indexed journals, in the PubMed, Embase, and all these, 1057 was seen as, after removing all the duplicates. And out of these 1057, again, some of the articles which did not met our requirements, or they were some simply case reports or animal experiments, they were again discarded off. Finally, 15 full articles came into the picture, and out of those also, again, which were not according to our primary or secondary outcomes, they were discarded. Finally, we were left with 5 studies, and these 5 studies were included in the quantitative synthesis. These 5 studies, and in total patients, if I say, so that was around 568 patients in these 5 studies that we will be discussing now. Outcome measures. Outcome measures are primary and secondary. Primary are majorly to clinical pregnancy rate and live birth rate. Secondary outcomes are 3 or 4, like retrieved oocytes, mature oocytes, blastocysts, growing follicles, transferable embryos, fertilization and implantation rate. To make it more comprehensive, to make it more in a similar manner, the clinical pregnancy rate and a live birth rate, they were also exactly defined so that there is no controversy regarding it. So clinical pregnancy rate was number of successful pregnancies seen on ultrasound divided by the number of transplant cycles. Then live birth rate, number of final live births divided by the number of transplant cycles. Similarly, miscarriage rate also. So coming to the studies as such, I have tried to make it in a tabular form and in a comparative form so that all of us can have can understand in a comparative manner. It's easier to analyze the studies. That's why I have made it in a comprehensive manner rather than discussing each and every study individually. So I'll start with this table. If you go ahead, there are 3 studies which are mentioned in this, and the second table, 2 studies are mentioned in that. First is this Bara et al. From the Italy. The country of origin is Italy, published in 2020. The period of study was from 2015 to 2019. It was a retrospective cohort, and 2 groups were made. 2 groups is case and control. One is the Dinogest group, and the second is no hormonal treatment group. So interventions or material and method, when we talk about the material and method of interventions, in the Dinogest group, 2 milligram daily dose 3 months prior to IVF. Simple as that. 2 milligram daily dose 3 months prior to IVF. And the non-hormonal group, direct IVF, the patients were taken. Number of patients in each group were 63 in the Dinogest group and 88 in the non-hormonal treatment group. Then the next column is of age. Age is approximately comparable in both the groups. And then BMI, again comparable. BMI is 20 plus minus 2 kilogram per meter square in the non-hormonal group, 21 plus minus 3 kilogram per meter square. Staging. Now, one thing that's in all the studies, these 5 studies, this is one of the, in fact, limitation that staging was not mentioned separately in all the studies. So some studies which have taken into account staging as an as an parameter that I have included, but in few studies it was not attaining, similar with the previous treatment. So these two I will say that these two are basically limitations of our meta-analysis, because these are not comparable in all the studies. But in this Bara et al., this particular study, the previous treatment has been mentioned. These patients, whether in case group or the control group, both of them had failed ET cycles. In first group, 1.4 plus minus 0.5, and second group, 1.6 plus minus 0.4. FSH values, 7.8 international units per ml, again comparable approximately. AMH and AFC not mentioned in the control group. Outcomes, as I said, primary and secondary outcomes are more or less the same in all of them. Clinical pregnancy rate, live birth rate, mature oocytes, blastocyst formation, transferable embryos, and implantation rate. Second study is from Tamur et al. From Japan, published in 2019. It is from the period of study was from 2010 to 2015. It was a prospective cohort, means they took the patient, made the group, and then studied the effect of Dynogest further. So this Tamur et al., they made two groups. One group was of this Dynogest patients. Again, 3 months daily, 2 milligram, once daily dose, and before IVF. Now, the second group. This group was very interesting because in this group only they have used GnRH analogs, but in a long protocol that we used to do, or in fact now also we do for some patients, in which in the previous cycle, 21 day of the cycle, when we start using GnRH agonist, here we use mainly leupride 1 milligram, and then we decrease the dose later. But here they are using intranasal a spray of GnRH analog 900 microgram per day, buserelin acetate. So buserelin acetate was used 21st day of the previous luteal cycle till the time of the HCG injection. That is the trigger that we use for ovulation induction. So in Tamur et al., first group was Dynogest, and second group was this GnRH analog long protocol using intranasal spray of buserelin. The number of patients or in both the groups is comparable, 30 in the first group, Dynogest, and 34 in the next group. Age is again 34 plus minus 2, 33 plus minus 2. And in this Tamur et al., they have mentioned staging also. So third and fourth, if we see the first group, the Dynogest group, third and fourth staging is of 16 patients. So likewise, first and second staging is for 14 patients. There is no mention of the previous treatment, neither in fact all the biochemical parameters of hormones, but the outcome measures are again clinical pregnancy rate, live birth rate, implantation, fertilization rate, and retrieved and mature oocytes. And this study, which is from Russia, Muller et al., country of origin of the study is Russia, published in 2017, and the time period of the study is from 2012 to 2015. It was again a prospective cohort where Dynogest was used for 6 months daily before IVF. So in this particular, in fact, baki sub studies mein, this is the only where the duration of Dynogest dose is same, but the duration is increased from 3 to 6 months. So Muller is the only one where 6 months Dynogest is being used. And the second group, where 36 patients were taken, no hormonal treatment, direct IVF. This is the situation. Age is comparable in both the groups, BMI, and is again comparable in both the groups. And the outcomes which were measured, just two, clinical pregnancy rate and live birth rate. So this was the situation. Coming to the last two studies that we will be discussing. Purposefully, I am going to discuss the first, that Iwami et al., in the end for some reason, and I'll discuss why. The first we are with the Khalifa study. Khalifa is from, Egypt. Yeah, country of origin is Egypt. It was published in 2021, and the period of study is from 2018 to 2019. It was a parallel open label random control trial. Khalifa's study was very nice because it was an open RCT, and it was, I think, double-blinded RCT also. DNG, Dynogest, and short-acting GnRHA. And short-acting means, how did they did? They gave 2 mg Dynogest tablet orally daily for 3 months in the last 3 weeks of the pre-treatment period. Then short-acting GnRH agonist in a dose of 0.5 milligram subcutaneous leupride daily, followed by ovarian stimulation when DNG was stopped. Or another, if I want to make it simpler, so for first 3 months, they started with, they gave Dynogest. And the last 3 months, in the last 3 weeks, again, the luteal phase of the previous cycle, as we used to do, as we normally use our long protocol. So this long protocol similarly was used, but here that's 0.5 mg of leuprolide and then controlled ovarian hyperstimulation as we do normally, that was used, and then Dynogest was stopped. So it was, in other words, Dynogest followed by long protocol of GnRH agonist. Coming to the second group, this second group in Khalifa et al. Was GnRH ultra long protocol, means GnRH agonist in the form of depot, leuprolide acetate, 3.75 milligram subcutaneous monthly injections for 3 months before starting ovarian stimulation after the third dose of depot GnRH. Means 3 doses of leupride. I think many years, few years before, in fact, many people used to do this for grade 4 endometriomas. 3 doses of leuprolide acetate depot, 3.75 milligram, given for 3 months, and then starting with the ovarian stimulation. Number of patients in both the groups are same, 67. Age is comparable, BMI is comparable. Here staging is very nicely given. First and second stage may around 20 patients. Third and fourth, 47. Approximately comparable group in the GnRH ultra long protocol also. Then duration, other parameters of previous treatment or FSH, LH, the outcomes are again retrieved oocytes, mature oocytes, transferable embryos, clinical pregnancy rate. Khalifa et al. Didn't mention live birth rate, but it mentioned clinical pregnancy rate. Last studies of Iwami et al., that is from Japan. This study has a special mention because they basically used Dynogest as a PPOS cycle. If we see at the intervention, so intervention, it is written prior to ART, Dynogest 2 mg daily was started, and controlled ovarian hyperstimulation was started at individual discretion. Means basically a PPOS cycle where already the patient was on Dynogest and they started the ovarian stimulation. And in the second group, they used dydrogesterone 20 milligram daily along with COH, as we do in many of the PPOS cycle. So Iwami et al. Basically used the Dynogest as a PPOS, and patient was already taken Dynogest for some months. So this had again 71 and 74 patients in both the groups. Staging is mentioned, which is also comparable. First and second staging, 46 patients. Similarly, in second dydrogesterone group, again first and second staging, 59 patients. Third and fourth, 25 and 15 patients respectively. AMH, FSH, and antral follicle count, all of them are almost comparable, not a major difference in any of these. And again, the outcomes that we are that they analyzed was again live birth rate, clinical pregnancy rate, mature oocytes, growing follicles, and transferable embryos and blastocysts. So this was all the 5 studies that I discussed in nutshell. Again, if I want to summarize them, then you will see that Bara et al., Tamur, and Muller, they basically had Dynogest in 2 main studies. One group had no hormonal treatment. One had this GnRH long protocol using nasal, intranasal spray of buserelin. And in Khalifa et al., it was a randomized controlled trial where they used ultra long protocol of depot injections and a DNG, Dynogest plus leuprolide 0.5 mg that we use for our long protocol as such. Then at the last, Iwami et al. As a PPOS cycle. Coming to the results now. Since it's a meta-analysis and we will see the results, all the results in toto rather than individually. Although if you want, I can just say 2 or 3 lines about the individual results also, but then it might mislead us. So here we have to discuss the results in total. And that is why it is more or less in the tabular form only. But There is another thing that we will discuss today, and that is about the forest plotting. How the forest plotting gives us in fact, a better review of when we are comparing many studies together. So coming to the results now. When I start with the clinical pregnancy rate, that is the first aspect that we will see. So clinical pregnancy rate can be, or in any, all of the outcomes can be compared or can be discussed, can be analyzed in two methods. Either we see them individually as in each study, or we see them in toto. When, if you see this chart, as I told you earlier, that one group was the Dynogest group, and then the other group, that is the non-Dynogest group. So basically in the non-Dynogest group, the whole subgroups were made. These subgroups were, first of all, Dynogest with no treatment. Number two, Dynogest plus short-acting GnRH agonist versus ultra-long GnRH. Then Dynogest versus long GnRH. Then at last, Dynogest versus dydrogesterone. So these four subgroups were made, and our results were analyzed in this aspect only. And in all the parameters, whether clinical pregnancy rate or live birth rate, or even this mature oocyte growing follicles, everywhere the embryos, whether frozen or fresh, it was again compared. Embryos in these two formats, whether frozen or fresh, was compared. So coming to the clinical pregnancy rate, first of all. If I come to the clinical pregnancy forest plotting, so just two lines about what exactly do I want to show through this is, a forest plot is like a forest only, where each study contributes a tree to the forest, from which a trend may become evident. So even if the individual study is not statistically significant, we might see a trend in a forest plot. So the vertical line that we are seeing here is the null hypothesis. This small in front of the every study, these small square formats, these are basically the weightage of a study. For example, Ivami et al. Has a bit broader square. It means that this study has more weightage. The reason being, size of the square represents the weightage of the study because of the sample size and the statistical power of that study. And that is how it has been depicted. Smaller squares means that study carries a smaller weightage. Then if we see overall in the clinical pregnancy rate, the p-value is 0.001, 0.01 means in clinical pregnancy rate, if I say the results, combine and coming to this format. Combined analysis demonstrates that Dynogest group had a comparable clinical pregnancy rate to the non-Dynogest group. Means if we say to the first line, the overall, think, is it visible? The p-value is visible to everybody?
Yes, it is visible. You can continue.
Okay, p-value is visible now. So in overall group, the p-value is 0.284, means it's not significant. That overall if we see, but the Dynogest group was illustrated to have a significantly higher clinical pregnancy rate than the non-hormonal treatment. So compared to the non-hormonal treatment group, where we can see the p-value is 0. Yeah, where the p-value is 0.003. Here, Dynogest versus no treatment. So in this particular group, we can see that the significant higher number of clinical pregnancy rate was seen. Although coming to other subgroups, no significant difference was identified between the Dynogest plus short-acting GnRH agonist group and the versus ultra-long GnRH protocol. So in any of the other groups, in any of the other subgroups, there was no significant difference in the clinical pregnancy rate. As far as patients undergoing fresh embryo transfer is concerned, the Dynogest group displayed a significantly increased clinical pregnancy rate. So in fresh embryo transfer, the clinical pregnancy rate was significantly higher, and Dynogest versus no treatment at all, the significance difference was seen. Otherwise, when compared to Dynogest versus dydrogesterone or Dynogest versus long GnRH agonist or even short this ultra long protocol, the difference was not this much. Similar situation is there in our forest plotting also. The final overall case on this diamond kind of a depiction, it shows us finally what is the trend of the study. Coming to the live birth rate. Earlier we discussed it was clinical pregnancy rate, now the live birth rate. So coming to live birth rate, again, overall 4 studies were included in that, and 4 studies may, if we see the p-value, the subgroup analysis say the patients treated with Dynogest were found to have a comparable live birth to those not treated with Dynogest on a pooled basis. But in subgroup analysis, based on different grouping methods, Dynogest versus non-hormonal treatment group, Dynogest versus long GnRHA. So only that Dynogest group had a significantly greater live birth than the non-hormonal treatment group, where the p-value is 0.008. And Dynogest group had a significantly reduced live birth as compared to long GnRHA protocol. As compared to GnRH agonist, there was no significant difference. Otherwise, it was in fact reduced. Only when we are comparing with the no treatment, then there is significant difference that we can see. And again, while using fresh embryos, patients with Dynogest treatment had an increased live birth rate compared with those without DNG treatment, where the p-value is again 0.027. So these are the 2 conditions, Dynogest versus no hormone, no treatment at all. That group only is showing improvement or significant difference. This is the again a forest plot which is showing live birth rate, and these 5 studies, Ivami et al., Bara et al., Tamura and Muller, only Khalifa did not mention live birth rate. So all these are showing the similar results. Compared to the implantation rate, similar condition was seen in the implantation and other also. So basically, if I want to summarize, no, I think before that, I think retrieved oocytes and mature oocytes, they need a mention because many patients we take with Dynogest or after Dynogest, how our ovulation induction trends show. So to retrieved oocytes, 2 studies, basically Khalifa and another study, they assessed the influence of Dynogest pre-treatment on the number of retrieved oocytes. Overall analysis showed that Dynogest and non-Dynogest groups had the comparable number of retrieved oocytes. Subgroup analysis, if we see, it shows that based on the grouping approaches, number of retrieved oocytes was similar to DNG plus short-acting GnRHA group and the ultra-long protocol. In fact, Dynogest group had fewer retrieved oocytes as compared to long GnRHA groups. Therefore, it was seen that retrieved oocytes were lesser, but on the contrary, mature oocytes with Dynogest were higher. So mature oocytes were on a higher number. Just see, the number of mature oocytes in the Dynogest group was equivalent to that in non-Dynogest group, and DNG group was demonstrated to have a more mature oocytes than the non-hormonal treatment group. We can see here in this group 0.045 is the p-value. So mature oocytes was more, although the retrieved oocytes was less as compared to the non-hormonal treatment group, and patients with Dynogest plus short-acting GnRHA treatment had a smaller number of mature oocytes than those receiving ultra-long GnRHA groups. Hence, it was seen that in all the cases, when Dynogest was compared to no treatment at all, the results were significantly better only. This is a plotting of, I think, mature oocytes. Yeah. Tamura et al. And Khalifa et al., they both used, and p-value is 0.028. Coming to some last secondary outcomes, which was blastocyst and transferable embryos. Blastocyst transferable embryos were, they had in fact showed no very the difference was not that much. Still, I will just mention 2 lines about it. Dynogest treatment, sorry, blastocysts and transferable embryos. I'm saying first the blastocysts. Bara et al. And Tamura et al. These 2 studies basically only they included blastocyst formation. No other study had included blastocyst formation, and they saw that Dynogest treatment was found to have an equivalent effect on the number of blastocysts to the non-DNG group. But there was a significant difference in the fresh group. Furthermore, subgroup analysis demonstrated no significant difference in the number of blastocysts between the Dynogest group and the non-hormonal treatment group. And the I think fresh embryos was only more. In transferable embryos, number of transferable embryos was evaluated in 2 publications only. It was presented by a combined analysis that Dynogest and non-Dynogest treatment exerted similar influence on the number of transferable embryos. Further, the number of transferable embryos was comparable in the Dynogest and non-hormonal treatment group. Hence, there was no significant difference as far as transferable embryos was concerned, even in blastocysts. Fertilization rate, even in fertilization rate, overall or whether in subgroups also, no significant difference was seen. All the p-values were, even with fresh embryo or frozen embryo, all the p-values were more than 0.05. Hence, none of them were significant. So this was all about the primary and secondary outcomes, and the final, although we will conclude it more and we'll discuss it more, but results were analyzed basis on that only. A little bit about the Dynogest as such. Dynogest is a 4th-generation progesterone, and it is very useful when the endometriosis treatment as such is concerned, when even patients who are not suffering from infertility, it is very well tolerated drug, and it helps a lot in effective in relieving the pain. It has high oral bioavailability, which is in fact over 90%, and it has short plasma half-life time of around 10 hours. So basically, there is no risk of accumulation. Side effects are very less. Even if repeated administration, it does not accumulate in the body. A dosage of once a day OD treatment or OD dosage is required and well tolerated. DNG has important progestational effect. It suppresses gonadotropic release, but at the same time, it does not have any glucocorticoid or mineralocorticoid effect. Means it does not have a estrogen mimicking like effect. Therefore, it has very important differentiating aspect from the GnRH analog or other, in fact, oral contraceptive pills. There is no estrogen-like impact in vivo experiments. Compared with the activity of inhibiting ovulation, DNG has stronger activity on the endometrium. This is such an important aspect of it. Dynogest has a specific affinity for the endometrial receptors. It helps in changing the molecular environment of the endometrium as such. It does not affect inhibitory influence on the ovaries. That is why ovulation is not suppressed. Ovulation is not affected that much by using Dynogest. That's a very important aspect of this molecule. And when we see at the molecular level, DNG stimulates the proliferative cells and endometrial stromal cells. It basically suppresses their proliferation. It suppresses aromatase and other COX-2 expressions. Coming to the interleukins, IL-8, IL-6, tumor necrosis alpha, all these parameters basically which cause inflammation at the molecular level, they are hindered by and inhibited by Dynogest. Furthermore, antigen presenting function of peritoneal fluid is through HLA. And main important aspect that I want to highlight is this particular word, which is hypoestrogenic state. Mainly what happens is Dynogest is creating a hypoestrogenic state in the endometrial tissue, but it does not excessively reduce the plasma estradiol level, which is the problem with GnRH analogs. When we were using GnRH analogs, whether depots in more than 3 months, it was such a big problem because the side effects of using GnRH analog, it basically suppresses the entire HPO axis. That problem is not faced with Dynogest. There is a hypoestrogenic state which it creates, but it is locally at the endometrial tissue level only, and which is often stable at the lower limit of the normal concentration range. Compared with GnRH analogs, such estradiol levels are not expected to cause reactivation of endometriotic lesions, whereas they are high enough to prevent hot flashes and bone loss. So there is no flare-up effect also. These two aspects really make this molecule stand apart from GnRH analogs. In conclusion, in clinical practice, we can say that Dynogest could be administered over non-hormonal treatment to improve the clinical pregnancy rate and live birth rate. Although, as we saw, all the parameters, they do not show any statistical significance. But again, if I want to re-summarize or summarize the whole assessment, I would say that Dynogest treatment may have comparable effects to non-Dynogest treatment over on this IVF outcomes. The clinical pregnancy rate and live birth rate in the Dynogest group may be significantly greater than those in the non-hormonal treatment group. These findings indicated that Dynogest may be administrable over non-hormonal treatment to improve the clinical pregnancy rate. But at the same time, this drug might be used alone with caution for patients with endometriosis who would undergo IVF-ET, because when we are using Dynogest in combination with short-acting GnRHA, like in one study, in fact, it gives a more better outcome. So clinical pregnancy rate and live birth rate following long GnRHA treatment was shown to be greater than those after DNG use. And the dydrogesterone group displayed the elevated number of mature oocytes versus the Dynogest group, for which more research is warranted. Hence, in fact, Dynogest in combination with GnRHA had better outcomes in 1 or 2 studies. Finally, patients receiving Dynogest combined with short-acting GnRH agonists showed fewer mature oocytes than those receiving ultra-long GnRHA, indicating that the combined medication of DNG needs further clinical validation. Coming at last to the limitations, I think I mentioned earlier also, amount of eligible literature for analysis was relatively small, and I think more clinical studies are required to ensure the stability of results. Not all included studies reported the staging of the disease or the kind of the surgery that the patients had. Yes, the surgery for cystectomy, endometriosis ke liye, that was not mentioned. And whether patients had removal of endometrioma or adhesions or bowel resection, that was not mentioned in the studies. No included studies reported whether the patients had previous GnRH antagonist treatment or some other long-term hormone therapy if somebody was taking. It was focused on the population planning to undergo IVF following laparoscopic removal of endometriomas, with no endometriomas or other ovarian cysts at the start of the stimulation. So only a particular group of patients were taken in few studies. So these, I think, were some of the limitations. Thank you. Thanks a lot. I think now the meta-analysis.
Thank you, Dr. Anuj, for the presentation. And I would request Dr. Leena Wadhwa ma'am and Dr. Gunjan Bhatnagar ma'am to kindly take over the discussion.
Yeah, thank you, Dr. Anuj. It was a very nice presentation, and you nicely, deeply went through the literature, and you have taken us through each and every study. Although the limitation of this meta-analysis is very clear, that most of the studies, 3 were cohort, 1 was retrospective, and 1 was only RCT. So I think that was a big disadvantage, I'll say, or limitation of the study. You can, I think, stop screen sharing.
Yeah.
Yeah, so that it is open for discussion also. And one thing is, you also highlighted that many of the patients who had undergone cystectomy or they were symptomatic, having pain, those were the patients, they were put on Dynogest prior to ART,
Yeah,
right?
maybe.
The last line which you mentioned.
I think yes.
So there was difference in the groups also. And another thing, what Dr. Yukti has also pointed out is it's not clear when the Dynogest was stopped. In few studies, they have stopped before COH, and maybe in they have continued. It is not clear. Would you like?
No, I think it's only in one study. It's a bit difficult to make out, but in most of the studies, it is 3 months prior to IVF. they started, and then at the start of the stimulation, it was stopped.
In all the studies?
Not all. That I'll start with this Muller et al. Yeah, Dynogest taken for 6 months. Tamura et al. Dynogest taken for 3 months. And then Bara et al. Dynogest taken for 3 months. Characteristically, it is written. It's only with Khalifa who used Dynogest along with short-acting GnRHA. They continued it along with short-acting GnRHA. Only in the PPOS cycle, the Ivami et al., which I mentioned in the last, they have not said anything about how many days the patient was taking DNG prior to it. But yes, because it was a PPOS cycle, so throughout the COH, throughout the stimulation, patient was still taking Dynogest. So two studies was taking Dynogest all throughout the stimulation. And
Oh, that also creates a bias. That's also one of the limitation when we are comparing the studies.
Yeah, we can say, yeah.
Yeah, and one very important thing about Dynogest, which I was reading, is that Dynogest leads to restrained follicular development and induced follicular atresia. So the number of growing follicles, they were found to be smaller after Dynogest. So this is one thing which needs more further studies.
Yeah,
Even
she
retrieved
mentioned,
oocytes
he
was
mentioned
lesser.
also the mature oocytes were better, but the number was
Retrieved
smaller.
was less, yes.
Yeah.
Growing follicles less.
Yes.
True.
Size is also smaller with Dynogest.
Yes, ma'am.
Very nice presentation, Dr. Anuj. Very well, you had tabulated the entire thing. That was one good thing you have done for us to look at the studies. Yeah, I just wanted to know, like we were using the long protocol and ultra long protocols, which were all eradicated, which was what the ESHRE came out in 2022, that the long and ultra long are no more being given, and we can straight away go for IVF. And these protocols do not help as much as we were used to be thinking of this. The requirement, because I think the requirement of gonadotrophins used to increase with a longer ultragrown protocol, the total duration, total dosage, that was increased. So, did you find any effect of Dynogest, like increase in the dosage or increase in the number of days required prior to the Dynogest treatment? Was there any mention? I did not find any mention of that
No
in the study.
mention, ma'am.
Mm-hmm.
It's only the randomized control trial, Khalifa et al. There is only one. It has
Mm-hmm.
simply said that which compared two groups. One group was GnRHA in the form of depot 3 months prior to the stimulation. They used one group 3 months monthly injections of depot, and the other group Dynogest plus short acting. So they only said that our pregnancy outcomes are same in both the groups. Our ovarian response is also same, but certainly cost of treatment has decreased with Dynogest. That is only mentioned. The
Okay.
cost of treatment has
Decrease would
decreased.
mean the dosage would decrease.
But the dosage they didn't mention.
All right. All right.
Because
But
in
I agree with Dr. Gunjan
Yes,
that
ma'am.
now ESHRE does not recommend the use of GnRH analog prior to controlled ovarian hyperstimulation. Rather,
Right.
it is prior to embryo transfer.
Yeah,
3 doses.
segmented IVF. Yeah,
Yeah, that gives better results
yeah,
prior to frozen embryo transfer if you give 3 doses of GnRH analog.
Also, I was reading about this newer antagonist, elagolix, which is being tried prior to IVF. There is one pregnant study being done. The results are still awaited, and they are giving but and the advantage with elagolix is that it has to be given for only 12 days, like because it does not have any flare effect unlike gonadotrophin agonist. So it directly starts suppressing the endometriotic lesion, and it has to be given for 12 days, but yes, the results are still awaited.
Ma'am, in fact, I wanted to ask for before frozen embryo transfer, adenomyosis is such a difficult thing to treat. For that, in fact, I have used Dynogest along with this leuprolide depot, and it worked actually in 2-3 patients. So, what do you say, ma'am, for Dynogest and combination of this leuprolide depot?
What
before
I
frozen
usually do,
transfer.
yeah,
As
I
you
just look at the size of the adenomyosis. If the width of the uterus is more than 12 centimeter or the endomyometrial junction is more affected, then we do a pre-treatment with, I just give a one depot because the long and ultra long are supposed to be the similar in terms of results. But if the endomyometrial junction is not affected and the uterine size is not very much, the uterus is not very bulky, then I generally do not. I just give one dose of depot and then I go ahead with my transfer. In one of my patient, I had used letrozole. I remember that patient very clearly. It was a very big uterus, around 16 week size, and I gave her a letrozole for around 1 month prior to transfers. Luckily, she got pregnant. She has delivered now. So there is a role of letrozole also, which has been described in these cases.
Yeah,
because
you try
aerobic.
everything in such cases.
Yeah.
But then, ma'am, this endomyometrial junction is completely blurred. It is hazy, and the hooked down, crooked down, ET in such cases, and there are n number of these kind of cases.
Yeah.
So for these frozen embryo transfers, how do you prepare the endometrium?
Just I would let you this is my personal experience. I do transabdominal scan in all these patients because of with a full bladder because TVS is really difficult. The uterus, the cavity is retroverted, uterus is turned pulled back. So a full
Yeah.
abdomen scan is better to make out the endometrium. And if the endometrium is more than like is more than 7 mm, you can go ahead with the transfer. Because long term giving a long dose in 3 months duration does not make any difference according to the studies. So even I don't give it for a long duration.
Well, we are using long duration for 3 months with
Hmm.
big, huge adenomyosis, big endometriomas, and we are getting good results. Then we don't wait for the periods. If the ET is suppressed, you can
Right.
start with HRT and do the frozen embryo transfer.
Start
Ma'am,
with
there are a
the
few questions in the chat box, Dr. Anuj, if you can address that based on your journal.
Yeah, Dr. Gunjan, you can take up. I'm having a bad voice.
Yes. So we have discussed the first one. The second one is Dr. Prashant. He needs to know the effect of Dynogest on AFC and AMH levels and how long it can be used for better FET for better outcomes. Uh,
I couldn't find any study, in fact, in these studies, who could mention the change in AFC level because of Dynogest. There was no such mentions, and even AMH also. And I don't think Dynogest as such affects the antral follicle count
right.
also.
Yes.
Still,
Yes.
that was not mentioned. Also.
So I don't think there's a need of repeating the AMH levels and AFC levels once you have categorized your patient into a poor responder or a normal responder. So I don't think there's actually a need. Ma'am, Leena, ma'am, what do you
Mhm.
say about this?
Yeah, we are not doing checking this.
Levels
It
again.
needs further studies, I think, to see the effect of DNG on AFC and AMH.
Mm-hmm. So Dr. Yukti is asking if we need a washout period of 5 days or such before commencing IVF. Like what I think you have already answered the time of stopping your dynogest before.
Yeah.
So do they mention any washout period? I don't think the studies have mentioned about it.
There was no mention as such. But patients as such will be amenorrheic, so we can always see the down regulation done through E2 and LH levels, and then we can start.
Right. The third one is how were the most of these patients diagnosed with endometriosis before the cycle, clinically, laparoscopically, or presence of endometriomas?
I think there was that's what I said. The staging was not mentioned in all. All those patients where the staging was mentioned, I think 3 or 4 and above, any endometrioma if present is obviously 3 and above. So uh, I think endometrioma, presence of that was only taken into consideration. Laparoscopy and all was not mentioned at all.
Yeah. I think a TVS is good enough to identify plus the clinical symptoms of the patient. Okay. So there are no more questions there.
I think we can wind up now.
Uh,
Yeah, thank you, Dr. Anuj, for the wonderful presentation. It was very good.
Thank you, ma'am.
And we would like to thank Dr. Ankita and Dr. Nisha, who are the coordinators, along with Dr. Niru, for this wonderful Young Turks group. It is doing very well. Congratulations to the whole team. Thank you, Dr. Ankita.
Thank you so
Many
much, ma'am.
congratulations
Thank
to
you
all
so
of you
much.
for,
And thank you, Dr.
yeah,
Anuj.
many
Thank you, Dr. Leena.
congratulations
And
from my
thank you,
side
Dr.
too.
Gunjan, for the lovely discussion.
Yeah.
Thank
Thank
you.
you.
Good night.
Thank you. Good
Okay.
night, everyone.
Ma'am, thank you.